friends. Today our guest speaker is Dr. Leena Speth. I'll introduce her formally a little later. This webinar is brought to you by Mumbai Hematology Group, supported by Dr. Reddy's and managed by Mice Ideas. I'm grateful to Dr. Reddy's for supporting it, Mr. Rajesh, Kalpesh, and the team from Mice Ideas to look after the whole webinar, the Executive Committee of Mumbai Hematology Group, which is so supportive. Our guest speaker, Dr. Leena Speth from Denmark. She was our guest just 3 years ago. Our chief guest, Dr. Siddharth Lester, and I'll introduce him again a little later. Discussants of today's webinar, and all of you for sparing your Sunday morning. Let me introduce the next weekend activities. Next Saturday, 7 o'clock, we have Dr. Sagar Lonier from Atlanta speaking to us on myeloma. And next Sunday, we have our own Dr. Neeraj Arora from Ahmedabad speaking to us on molecular testing in lymphomas and lymphoproliferative disorders, which will be as usual at 11:30 a.m. Discussants for today are Dr. Ritu Jain. She's medical oncologist, Jasper Hospital, Mumbai. Dr. Shyam Agrawal, Director, Navodaya Cancer Hospital Research Center, Bhopal. Dr. Virendra Bhandari, Professor and Head Radiation Oncology at Sri Aurobindo Medical College and PG Institute, Indore. Dr. Bhavin Shah, Consultant Medical Oncologist, Hematologist, Director, Hemato-Oncology Clinic, Vedanta, Ahmedabad. Satish Kumar, Hematologist, Hemato-Oncologist, Columbia Asia Referral Hospital at Bengaluru. Dr. Nehal Khanna, Professor and Consultant, Radiation Oncology, Tata Memorial Hospital, Mumbai. Dr. Stalin Bala, Assistant Professor, Department of Medical Oncology at Nizam Institute of Medical Science, Hyderabad. Dr. Sachin Jain, Consultant Pediatric and Adult Hemato-Oncologist, Ayush Hemato-Onco Clinic, Assistant Professor at Anand Institute of Medical Science and Research Center, Udaipur. Dr. Karuna Kumar, Consultant Hematologist, Hemato-Oncologist and Bone Marrow Transplant Physician, Chairman, Transfusion Safety Committee, Yashoda Hospital, Secunderabad. And Dr. Balakrishna Padate, Consultant Hematologist, Oncologist and Bone Marrow Transplant Physician at PD Hinduja Hospital, Mumbai. As usual, we are going to have the quiz today. So I will just put up this quiz for the postgraduate students. A 44-year-old female patient had sudden onset of diminished vision, chest and abdominal discomfort. Her hemogram showed that the hemoglobin is good, the white cell count is normal, the differential white cell count is normal, the platelet count is 1.2 million. The ESR is normal. We'll now show you two pictures of CT aortogram, one of thoracic and one of abdomen, and we will show you a picture of fundoscopy. The question to you are two. One, what does the aortogram show? And two, what is the fundoscopy showing? As usual, whoever is correct for both the answers and first to reply would get the prize. You all know the email ID on which you have to send the correct reply. mbagarwal1@gmail.com. MB Agarwal is AGARWAL 1@gmail.com. So that's the first picture of CT aortogram. And you have to look at the abnormality and diagnose the abnormality. And there is similar abnormality in this CT aortogram, which is going right up to the abdomen. Both together have the same pathology, so you have to answer in a single way. Both show the same thing. Then you have the fundoscopy picture of the same lady. So you can reply at mbagarwal1@gmail.com. Okay. Well, it's now my privilege to introduce our today's guest speaker, Dr. Lena Spett. She's professor of oncology at the University of Copenhagen, Denmark since 2009. She completed her training in clinical oncology at the University Hospital of Copenhagen. She held a research fellowship for 3 years at the Danish Cancer Society. She obtained her PhD degree with work on prognostic factors in Hodgkin lymphoma. She is chief oncologist at the departments of oncology and hematology at Rigshospitalet, University of Copenhagen since 2001. Her main areas of research and clinical interest are lymphomas and head and neck cancer. She is the author of over 300 research articles and educational papers, including ESMO guidelines on peripheral T-cell lymphomas and cutaneous lymphomas. She has authored 3 textbooks, 27 book chapters, more than 500 oral presentations and posters at national and international meetings, 180 invited international lectures with H-index 66. She has supervised 18 PhD projects and numerous postdoc, postgraduate, and pre-graduate projects. She is editor of the Cochrane Hematological Malignancies Group and member of the advisory board for EPTA Oncological. She is chairman of the Danish Hodgkin Lymphoma Group. She is vice president of the International Lymphoma Radiation Oncology Group. She has received various awards. A few of them include the Oncology Award, Danish Society of Oncology 2004, Bunch Jensen Foundation Prize 2010, Global Excellence in Health 2010, renewed 2014. Well, after introducing our speaker, now it's time to introduce our chief guest who will be inaugurating this webinar. It's my pleasure to introduce my friend, Dr. Siddharth Laskar. Dr. Siddharth Laskar is well known to each and everybody in this part of the world. However, we have almost 100 trainees who have joined, and we have almost 100 participants from outside the country. And for them, he is Deputy Director Academics at the prestigious Tata Memorial Center, Mumbai. He is Professor, Department of Radiation Oncology at Tata Memorial Hospital, Mumbai. He specializes in pediatric, hematolymphoid, and musculoskeletal malignancies. Research areas of special interest to him include brachytherapy, intensity modulated radiation therapy, image-guided radiotherapy, extracranial stereotaxy, magna field irradiation. Well, I request now Dr. Siddharth Laskar to inaugurate this webinar and give us some words of wisdom.
Thank you very much, Dr. Agarwal, for this invitation. I don't know whether I deserve this privilege of being the chief guest, but thank you anyway. You asked me to say something on other than lymphomas, but I'll try to say something which mixes lymphomas and a little bit of a philosophy behind. So thank you, Dr. Agarwal, again, and thank you, the entire team of Mumbai Hematology Group, for doing such a wonderful job of continuing these educational endeavors, which has been going on for many years now. And a lot of us, and many of us, have actually benefited from these webinars and conferences that Dr. Agarwal and the MHG organizes across the country and even beyond the country. So thank you very much for that. Coming to today's topic, where we are discussing radiotherapy for lymphomas, we all know that lymphomas are extremely sensitive to radiation, and they do get eradicated completely with even small doses of radiation. Now, what it says is radiation is extremely effective. That means it is a very effective tool. Now, and these results have been published long back in 1950s by Vera Peters, and also the use of LINAC extended field radiation by Henry Kaplan. Was again published in 1960s. That means we have radiation here as a tool that is so effective. Now, similarly, chemotherapy is also very, very effective. Now, the problem is, and that is what happens when you have, there comes the philosophy. The philosophy is how to utilize and use two effective individuals or two effective modalities or two effective departments in a way that is most productive and most useful for the purpose for which we are using these treatments. And there comes the trick. And it is very much possible that at times there are situations where one tries to prove that the other one is better, but the trick comes and the catch is how we can get these two together. Now, as specialists, it is very important for us and the youngsters especially to understand and appreciate the good things and the not very good things about the medicine that we practice. And if we understand these strengths and weaknesses well, that's where we'll be able to use these modalities in the best possible way. So there brings a little bit of a philosophy in a way that you should introspect and think what is the good thing in you and what is the good in the others, and then get the best out of mixing both of them. And that is exactly what has happened in lymphomas. Now, we understood that radiation works so well, then why use chemotherapy? We also know that chemotherapy works so well, then why use radiation? But we also understood that, listen, both have their side effects and both can be clubbed together. And that is what happened over the years. And the technology of radiation has changed over the years. From large fields, we have more advanced technologies now where you can reduce the side effects of radiation. We can conform radiation to smaller volumes and avoid toxicities. And similarly, chemotherapy has also developed in a way that we have better outcomes with chemotherapy and the side effects have also been reduced. And that is where we need to understand, be mature, and try to combine the good things of each other and then use them in such a way that the outcomes are best. And that is the basis of the current strategies that we try to develop now. And I'm sure Dr. Lina is going to explain to you how there has been a paradigm shift in the way we use radiation therapy and how we combine radiation therapy with chemotherapy, how we have reduced from the large total lymphoid radiations to involve site radiation therapy that we do now, and how we want to combine chemotherapy and radiation therapy in the best possible way for the best outcomes. And there comes the philosophy again that you need to combine, go beyond your egos of your own departments and your medicine that you practice, and try to combine with each other. So take you through, you have none other than Dr. Lena Specht. As Dr. Agarwal mentioned, she's been a doyen, not only in radiotherapy for lymphomas, but for general policy decisions for lymphomas. And I've had the honor and privilege of being knowing her for many years, and also serving in the steering committee for the International Lymphoma Radiation Oncology Group. And I'm sure we're going to have a fantastic presentation and a very useful presentation. So without taking much time, so I'll hand it back to Dr. Agarwal. Thank you very much and hope you enjoy the seminar. Thank you.
Thank you so much, Dr. Siddharth Laskar, for those very great words of wisdom. I'm sure that this is going to help the juniors in a very big way. The amalgamation of these two modalities of treatment and many more which have come up is the best way to treat cancer and cure cancer. And you brought it out beautifully in a short speech of 5 minutes. Thank you so much for honoring us by being the chief guest and inaugurating this webinar, where we have a wonderful personality like Dr. Lena Specht as the speaker. And now over to Dr. Lena. You can share your screen and start your speech.
Yes, sorry. Can you see it now? And can you,
you can just make it full screen.
and can you hear me?
Yes, we can.
Thank you. Very good. Thank you very much. I'd like to thank Professor Agarwal for inviting me to give this talk. I had a very nice time in Mumbai 3 years ago, and I would have enjoyed coming back, but this...
Sorry for the interruption, ma'am. Can you please put your slides on a slideshow mode?
I think my slide is on my...
You have to put it on slideshow mode, Dr. Lena.
Slide, yes. Well, I thought I did.
Maybe you do it again. Probably.
Is it your screen sharing is paused? It says. So why does it resume share? Oh, sorry. Can I? What are you seeing now? Are you seeing my?
The disclosures, yes.
Yeah, but it's not on slideshow, is it?
No, ma'am. It's not on the...
Now it's
yes,
ma'am.
ma'am.
Yeah, it's okay.
Is it on slideshow now?
Yes, ma'am. Please go ahead.
Yes.
Thank you. Thank you. Yes, I was just thanking Professor Agarwal for inviting me. I really enjoyed my stay in Mumbai 3 years ago, and I also would like to thank Siddhartha for his introduction, and I so agree with the things you're saying. So, and in fact, we were mentioning just before we started this that we are both in the steering committee of the International Lymphoma Radiation Oncology Group, as you heard, and we were actually supposed to have our large plenary meeting in Mumbai next month, but that will have to be next year. Looking forward to that. I'm going to talk about radiotherapy of lymphoma, and these are my disclosures. Now, as you've already heard, the development of lymphoma radiation volumes has been quite dramatic. From back in the 1950s to 70s, we did this total nodal irradiation where we irradiated all the major lymph node areas in the body. Huge amounts of normal tissues were irradiated, even in patients who just had disease in a small lymph node in the leg, for instance. When effective chemotherapy became available, we gradually reduced the volumes because we didn't need to treat a microscopic disease anymore with radiation therapy. So we went to the extended field radiotherapy, typically the mantle field we saw in Hodgkin lymphoma. And then in the 90s, we went to even smaller fields that involved field radiotherapy, but all of these still regional irradiation. Now in the mid 2005, just about, we changed radiotherapy for lymphomas dramatically into what we call involved site or involved node radiotherapy, which I'll get back to a little later. But it's important to remember that the information, the data we have on long-term complications from radiotherapy of lymphomas, these data stem from a time when patients were treated with these huge radiation fields, fields that we are not using anymore. They've been obsolete for quite some time. And so it's important to remember that the data we have, obviously for long-term complications, are from a time when we treated lymphomas very differently with radiation therapy. And we've also developed lymphoma radiation doses in the past, when radiotherapy was the only treatment modality that could cure lymphomas. People tended to go to doses as high as possible, and most lymphomas were treated to doses of about 40 gray. Based on the large randomized trials of the German Hodgkin study group, the early stage Hodgkin lymphoma favorable patients are now only treated with 20 gray, whereas early stage Hodgkin lymphoma with unfavorable characteristics are treated to 30 gray, at least if ABVD is the backbone of chemotherapy. If you go to even more intensive regimens, you can actually do with 20 gray in these as well. So much lower doses. For non-Hodgkin lymphomas, we have the large randomized trials of the British group that demonstrated that for aggressive non-Hodgkin lymphomas, a dose of 30 gray was sufficient, and for the indolent lymphomas, a dose of just 24 gray. And in fact, and this has actually, the update has just been published by Peter Hoskin. In the indolent lymphomas are exquisitely radiosensitive, and even a dose of 4 gray will provide complete remission in about 2/3 of patients. And so it was tested whether 4 gray was actually enough. It is not quite as good as 24 gray, but you do achieve remission in most patients, complete in 2/3 of patients. So this opens up new possibilities of using radiation therapy in particular the indolent lymphomas, because we can do with very, very low doses that have practically no side effects. So these dramatic reductions in radiation volumes and doses have, of course, led to equally dramatic reductions in normal tissue late effects. And it's important to remember some very simple facts, which, however, do tend to get sort of forgotten a little bit. These are quotations from Dr. Herman Soot, who was the chairman of the radiation oncology department at the Massachusetts General Hospital in Boston for many years. First of all, primary radiation injury never develops in unirradiated tissues. So if we avoid tissues, we avoid the primary radiation injury in them. And there is no advantage to any patient for any uninvolved tissue to receive any dose. And this is the philosophy that is underlying the modern radiation therapy of lymphomas, because we try to avoid all the normal tissues that is at all possible. So there has really been, as Professor Lasker mentioned, a paradigm shift in radiation therapy of lymphomas. We used to do these extended field or involved field radiotherapy, the mantle field or smaller fields, but still regional in the past. And these are reconstructions of these fields in a three-dimensional planning system, fields that were actually only planned two-dimensionally, because that was from the time when we did two-dimensional planning. We irradiated regions, whole regions, if there was any involvement at all, and often also prophylactically. And as this was two-dimensional planning and we couldn't see the tumor tissue, we used bony landmarks to define the fields and used fixed margins such as 1 or 2 or 3 centimeters from this and that structure. We have now moved into the modern era of radiation therapy for lymphomas, the so-called involved site or involved node radiotherapy. The difference is simply that if we have optimal imaging, we can make the irradiated volume the most conformal, that is involved node. But involved site, that is sort of the general name you have for it. And we have moved lymphomas into the modern techniques of radiation therapy. So it's now based on three-dimensional planning. So we can see the actual lymphoma involvement, and we can contour volumes and define margins according to the same principles that we use for solid tumors and using the internationally agreed principles of the ICIU. So in this way, we have reduced the volume that we are radiating, but it's not just that we have made the treatment field smaller. It is a veritable paradigm shift where we've moved into modern, highly conformal image-guided radiation therapy for lymphomas. So in fact, what we're doing now for lymphomas is much more mainstream radiation therapy, whereas the past very, very large fields were very special to lymphomas. What we're doing today in lymphomas is mainstream, highly conformal radiotherapy that radiation oncologists are used to in all tumor types. Because the novel technologies have really revolutionized radiation therapy in general and lymphoma radiation therapy too, of course. And these are the novel technologies in imaging, in computer technology, and in treatment machinery, which enables us to do today highly conformal, highly personalized, and individualized treatment. With regard to imaging, we now use all the imaging modalities available to us. In lymphomas, of course, particularly FDG PET scans, which are used in virtually all lymphoma types. And by using imaging in the optimal way, we are able to do pre-chemo PET-CT scans where we can contour the macroscopic lymphoma volume before treatment, before any treatment has been given. And then when we come to radiation therapy, after the chemotherapy has been given, we can use the post-chemotherapy planning CT scan and fuse it, use image fusion with the pre-chemo scans and with whatever other scan we need to get information from. And we can then modify for the changes during chemotherapy and end up with a clinical target volume that we are irradiating, which has been defined very, very precisely with all the information from imaging both before and after chemotherapy. And the computer technology has enabled us to do treatment planning in a much more sophisticated and much more precise way. Today we use what is called inverse planning, which is kind of doing the opposite of what we used to do. We feed the computer with images and contours and constraints, and then the computer optimizes the dose plan by iterative procedures, which require really large computer capacity, but that's of course available today, so that we can optimize the plan to cover the target with the full dose. That is the red shown here in the dose plan, which conforms almost exactly to what we define as the target for our treatment, whereas other structures are only getting very minor doses. In that way, we're able to avoid critical structures and only irradiate what we really need to irradiate. And then we have treatment machinery, which has become more and more sophisticated tools for high precision delivery of radiation therapy. We use intensity modulated radiotherapy, or the even, well, it's a kind of the same, but even smarter volumetric arc therapy. We've got tomotherapy and even proton therapy, which I understand you're now getting also in Mumbai. And we can use onboard imaging and cone-beam CT scans and motion management devices and even MR accelerators to achieve the highest precision possible. And you might then say that yours is a huge country, it's a low middle income country. Is that at all possible? Well, actually, you know, this is not that sophisticated. The techniques I have marked here with red are available on all modern machines. You can't buy a new treatment machine which cannot do these things. I know actually now many Indian radiation oncologists, very well trained, very much up to date. So yes, of course you can do this in India and in large countries in the low and middle income area, because this is something that is available, and you have got the people with the knowledge to do all this. Now I'll go now into the individual lymphoma types, some of the major ones, to discuss the role of radiotherapy and the evidence behind it. And I'll first go to early stage Hodgkin lymphoma. Now, I'm sure you all are aware of the 3 large randomized trials that have been debated now for many years in international meetings. Randomized trials of early stage Hodgkin lymphoma with PET-based tailoring of the treatment with regard to radiation therapy. The aim has been, and that is really because of the scare of radiotherapy that was induced by these very, very large treatment fields in the past. So a lot of the efforts in large trials have been to avoid radiation therapy. The thing is then that the radiation therapy has changed so much that it's a question whether that is the most important goal. But these 3 trials, the British RAPID trial, the EYTC LISA-FIL, that is the European collaboration, H10 trial, and now most recently the German Hodgkin study group, HD16 trial, are all early stage Hodgkin lymphoma trials, some of them in just favorable patients, testing whether a PET-based treatment tailoring could avoid radiation therapy in some patients. And I won't tire you with going through all the details of these trials. They have been extensively discussed before. All 3 trials showed improved progression-free survival when radiation therapy was used, in addition to chemotherapy, even in PET-negative patients. So in the RAPID trial, the difference was about 6%. That was after 3 cycles of ABVD. In the H10 trial, we tested both favorable and unfavorable, and the difference in the favorable group was 11.9%, in the unfavorable 2.5%. But then it must be noted that in the chemo alone arm in the H10 trial, we gave more chemotherapy. In fact, the unfavorable patients had full 6 cycles of ABVD if they didn't have radiation therapy. And the most recently published, the HD16 trial from the German group showed a difference of 7.3% after 2 cycles of ABVD in favorable Hodgkin lymphoma. So very consistently and a significant improvement in event-free survival, even in patients who were PET negative after 2 cycles of ABVD. So the conclusion of these studies is that radiation therapy cannot be omitted from standard combined modality treatment in early stage favorable Hodgkin lymphoma patients who are PET negative after 2 cycles of ABVD without a relevant loss of tumor control. And I think everybody agrees on that. In the early stage unfavorable patients, more intensive chemotherapy is used by the German Hodgkin study group and by varying degrees in centers in other places. And the HD17 trial of the German Hodgkin study group was recently published. In fact, it hasn't been published yet, but it is an oral presentation. You can actually find it on the International Lymphoma Radiation Oncology Group's website, which the address is here, and we'll back to it later. It's absolutely free, so you can go in and have a presentation by Professor Engert from the German Hodgkin study group presenting the HD17 trial. Now, the HD17 trial was for patients with unfavorable characteristics, and in the German Hodgkin study group, they have shown that the best chemotherapy for this group is the 2+2 regimen, 2 cycles of BRCA escalated followed by 2 cycles of ABVD. And in the patients who were then PET negative after these 4 cycles of treatment, they were randomized between 30 gray involved field or no radiation therapy. And the result of that randomization is shown here. There was no difference between the 2 arms. So if you're using a more intensive regimen, like 2 cycles of BRCA escalated followed by 2 cycles of ABVD, then there is no advantage to adding radiation therapy afterwards. The question is, of course, whether you want to use a regimen as aggressive as BRCA escalated for early stage Hodgkin lymphoma. But this is the evidence, and that is very recently presented by the German Hodgkin study group. Now, I want to discuss this a little bit further because, as I said, the use of BRCA escalated in early stage Hodgkin lymphoma may be debated. And then I'd like to draw your attention to the well-known fact of the incidence curve of Hodgkin lymphoma. And here is the incidence curve for the Scandinavian countries according to age. And as you know, it has got this bimodal incidence curve with a top at the around the 20 in young patients, and then notably another top after the age of 50 to 60 here in an older age group. And with a changing demography, and in my part of the world, this is very obvious, but it is coming in your part of the world also because your population is also aging. And in my part of the world, the over 65s years old people are projected to account for the majority of population growth and to constitute about 20% of the population in 2030, which is about the same number of people as the group of 15 to 30 years. So, and we are already seeing this. We're seeing Hodgkin lymphoma very commonly in the older age group, even into the 80s. We have to get used to the situation where Hodgkin lymphoma is no longer just a disease of the young. And when we look at the mortality curves of Hodgkin lymphoma, again, these are from the Nordic countries, and you can see that very, very few, fortunately, very, very few patients die of Hodgkin lymphoma in the younger age group. But when we get over the age of about 60, then the mortality curves rise very steeply. And it's not just because they die of old age or something like that. They do have a very significantly inferior survival compared to an age-matched group in the same countries. So the mortality is very high in the over 60s. And really, there is an unmet need for treatment tailored to the older age group. As I said, Hodgkin lymphoma, even Hodgkin lymphoma is now an increasing problem in older patients because the treatment results are not satisfactory. Almost all European trials have limited eligibility for trials in Hodgkin lymphoma to patients below the age of 60 to 65. So we don't have a lot of evidence on the treatment of these patients. The German Hodgkin study group included patients up to 75 in the early stage trials in favor of patients. But in actual fact, less than 5% of the patients in the German Hodgkin study trials in favor of disease were over 65. And with regard to intensification of treatment, BIRCOP escalated the highly intensive regimen developed by the German Hodgkin study group has been the main intensification tested. And this regimen is simply not relevant for patients over the age of 50 to 60. So that all the trials of improving outcome by intensifying treatment with BIRCOP escalated are simply not relevant for this older age group because they weren't tolerated. Older patients tolerate chemotherapy rather poorly. Even the ABVD regimen can be quite difficult to get through with in older patients. On the other hand, long-term toxicity concerns are different in older patients. I'll get back to that later on, but for instance, the risk of second malignancies, you simply cannot see a significant increase when you get over the age of about 50 or something like that. And the modern limited radiation therapy is very well tolerated, in fact, by older patients. And in these patients, achieving a durable remission is essential. With the primary treatment is essential because they won't tolerate intensive relapse treatment either. And it is still a fact that radiation therapy is the most effective treatment of Hodgkin lymphoma with respect to local control. It is in fact also true of the non-Hodgkin lymphomas. And it's important to remember this because we have a very powerful tool here. And therefore, radiation therapy has a particularly important role in the treatment of Hodgkin lymphoma in elderly patients, and of course also in the many, many patients with non-Hodgkin lymphomas who are often in the older age group. So with this, I'll go to the fairly rare Hodgkin lymphoma subtypes, the nodule lymphocyte predominant Hodgkin lymphoma. It constitutes only about 5% of all Hodgkin lymphomas, but there have been some interesting studies recently, which I'll go through. In the German Hodgkin study group, they did a long-term follow-up of patients with nodule lymphocyte predominant Hodgkin lymphoma treated in their trials. They had only 38 patients who were treated with radiation therapy only. But what you can see here is that this is a very indolent disease with a very good progression-free and overall survival. This is 12 years after treatment. But we can also see that there's a steady trickle of recurrences even many years after treatment, and that this is a disease that you are unlikely to die from, but that may recur and need treatment several times over many years. So this is the German Hodgkin study data. Of course, none of it is randomized. This is a disease that is too rare for randomized trials. And this is a publication from the Netherlands with primary therapy and survival in patients with nodule lymphocyte predominant Hodgkin lymphoma treated in the Netherlands from 1993 to 2016. And these are early stage patients. And as you can see here, they've split them up in the different treatments. And what you can see is that the overall survival with radiation therapy only or combined with radiation therapy only is excellent and just as good or perhaps even better than with the combined modality. And also, of course, that the stage of diagnosis is very important. In advanced stage is rare, but it's not quite as indolent as the early stages. But what you can see here is that the treatment with radiation therapy only in these patients certainly seems to be a very good option. And in the International Lymphoma Radiation Oncology Group, we recently published a study where we combined data from 18 institutions around the world to achieve more than 550 patients in the study treated in the modern era. Over 70% of them were staged with PET scans. So this is by far the largest material on nodule lymphocyte predominant Hodgkin lymphoma published. And half of them were treated with radiation therapy alone, almost as many with combined modality, and then a few with some of the other options here. And the important thing is here that you can see for progression-free survival and overall survival that the treatment with radiation therapy alone achieved as good results as combined modality treatment. So the conclusion here is that chemotherapy doesn't seem to add anything. So there's no good point in giving more than radiation therapy as the primary treatment of this disease. What we can also see is that in stage 1, this is true both in stage 1 and in stage 2, that the results with the radiation alone are just as good as if you add anything else. So the conclusion of these studies is that radiation therapy remains the treatment of choice for early stage nodular lymphocyte predominant Hodgkin lymphoma. Then we'll go to the non-Hodgkin lymphomas. And early stage diffuse large B-cell lymphoma. It's been debated for many years, and we don't have that much data on the treatment of early stage diffuse large B-cell lymphoma after the introduction of rituximab. We have some old randomized studies that I'm sure you're aware of, which demonstrated that a combined modality was generally superior to chemotherapy alone, but these studies were really hard to evaluate because it included patients with many different risk factors and not always possible to tease it out from the reports. Now, the question has been and continues to be, do we still need consolidative radiotherapy in these patients after they've had standard rituximab plus CHOP chemotherapy? And this is a study from the US National Cancer Database. So this is not randomized. It is a very large population, almost 60,000 patients that have been analyzed, and what you can see here is that the overall survival of these patients seems to be better when the patients are treated with combined modality compared to chemotherapy alone. And again, I must stress this is non-randomized, but it is a very, very large database. And this is the raw data as shown here on the left. On the right, you see the data after analyzing with the propensity score analysis, which tries to take account of the different prognostic factors in patients. Now, this cannot compensate for randomization, but it is a very large database that does seem to indicate that patients who are treated with combined modality do have better results than the ones treated with the chemotherapy alone. And even so, unfortunately, it seems that the use of radiation therapy in this group of patients is going down. Now the question is, why are we asking the question, should we avoid radiotherapy? The introduction of the immunotherapy with rituximab has improved results of chemotherapy alone, so that might perhaps indicate that it was no longer necessary to irradiate. And we have this knowledge of the late effect of radiation therapy, which has driven a trend to try to reduce or for improve the use of radiation therapy. But the question is, of course, is radiation therapy still needed? And PET assessment is being increasingly used to adapt lymphoma therapy. So the question has been, can we define groups where radiation therapy can be avoided if that is what you want? And I'd just like to comment on a couple of very recent publications that have been discussed a lot at different international meetings. The first one is the study by Lamy et al. For the LISA group in France, where they randomized patients, non-bulky, limited stage diffuse large B-cell lymphoma, to R-CHOP with or without radiation therapy. And in this study, they started out with about over 300 patients, and only they were randomized up front, but only the ones who achieved complete remission were then treated according to the randomization. All the patients with partial responders either got radiotherapy or some other treatment. But they ended up with 281 patients who were assigned to either R-CHOP or R-CHOP plus radiation therapy. the problems which I'd like to highlight, just to make you aware of them when you are seeing this study quoted, are several. First of all, 62 of these 281 patients, that is 19%, had complete resection of their tumor at initial surgery and were therefore PET negative at the outset. And we know that this group of patients who've already had complete local control by the diagnostic operation are not they're not likely to benefit from radiation therapy. And 5% of the patients who were randomized to radiotherapy never did receive it. So nearly 25% of all patients enrolled on this study would not be expected to contribute to determining the role of radiation therapy. So that's one thing. The next thing is that the results showed that there was no significant difference between the two arms. But the problems with the interpretation of this study, first of all, is that if you looked at the patterns of relapse, then 13 in the R-CHOP arm alone relapsed, and 5 of them at the initial site, whereas 10 relapsed in the radiation therapy arm, but never in the irradiated site. You can see here that this is a cumulative incidence of relapse, and the red line up here is the chemotherapy alone, and the dotted line down here is the radiation therapy arm. So it is very clear that radiotherapy is working. In fact, it's almost halving the cumulative incidence of relapse, but the trial is simply not powered to quantify the extent of a benefit when the magnitude is not bigger than this one. And this study was started. This study was a non-inferiority study, and there are several statistical problems which has a tendency to be overlooked, but very important here actually. They defined a margin of non-inferiority as a difference of 8% or less. The question is whether you think that an 8% increase in relapse risk is trivial. I kind of doubt it, but that was what they defined. And the results they report on the 5-year event-free survival was that it was 89% plus or minus 2.9% in the R-CHOP arm and 92% plus or minus 2.4% in the R-CHOP plus RT arm. And so there's a 3% absolute difference between the two arms, but with the 95% confidence intervals stretching from minus 8.3 to 2.3. In other words, this confidence intervals include the 8%. So there is the results of this study are compatible with a difference which is actually larger than 8%. So the correct statistical conclusion is that the study outcome is inconclusive and that non-inferiority has not been demonstrated. So frankly, the statistical evaluation of the results is actually not correct. There are other problems with the study. The patients entered in the study were the very lowest risk group with no bulk, and most of them with an MEP of 0. And this has been recognized as a group that will do just as well from 3 cycles of CHOP plus radiation therapy from the old SWOG trial. Whereas the patients with risk factors in this LAMI study, the French study, are too few to have sufficient power to assess the effect of radiation therapy in these groups separately. They use the R-CHOP 14 regimen. That is actually not standard, but we have to assume it's equivalent to R-CHOP 21. The PET assessment was visual only, so it's not really compatible with the Deauville criteria. And many of those who achieved complete remission actually received 6 cycles of R-CHOP. So that is really likely an overtreatment of these patients. And we really do have to consider anthracycline toxicity, which is very important. Also, the patients received 40 gray, which is probably an excessive radiation dose. So just to warn you that this study has some serious flaws that need to be taken into account. Then very recently, I believe at ASH, the FLIER trial was debated. Now, this is actually not a trial of radiation therapy at all, because patients didn't get radiotherapy in either arm, but it's been used in an argument regarding radiation therapy. So I think it's important to go through it. And this study tested whether 6 cycles of R-CHOP is really too much for the low-risk diffuse large B-cell lymphoma, and whether they could do with just 4 cycles and then extra rituximab to the full 6 cycles. So this was the trial design, and the results of the FLY trial, which was presented at ASH, well, a couple of years ago also, showed that there was no difference between the 2 arms. And of course, there was less toxicity with 4 cycles. And this was the overall survival results. So the interpretation of the FLY trial was basically that 4 cycles was as good as 6 cycles. But it has also been taken to an argument on radiation therapy, because we think that we know that 4 cycles of R-CHOP plus 2 cycles of rituximab are now, we know that that is as good as 6 cycles of R-CHOP. That's what the FLY trial demonstrated. And we think that we know that 6 cycles of R-CHOP are about as good as 3 to 4 cycles of R-CHOP plus radiation therapy. So it is then concluded that 4 cycles of R-CHOP is as good as 3 to 4 cycles of R-CHOP plus radiation therapy. And the argument here is that you can then do with 4 cycles of R-CHOP and do away with the radiation therapy. And the question is this really a fair interpretation? Obviously, what you see is that we are actually comparing arms from different trials. It's not a direct comparison, and it is really actually poor science. The trial that we need would be a trial of 3 or 4 cycles of R-CHOP plus or minus modern involved site radiation therapy. The expected benefit of the radiation therapy may be small, perhaps as low as 3% progression-free survival, as we saw from the estimates from the AMI trial. And that is, of course, because the outcome is so good in these low-risk patients with any whatever treatment approach we choose. But the question is, what side effects are we trying to avoid? The side effects of 30 gray involved site radiation therapy to these localized diffuse large B-cell lymphomas is likely to be very modest. They are very rarely located to the mediastinum. So for the majority of the patients in this group, the side effects are really very, very modest. So is that worth it? Should we risk anything for avoiding these very minor side effects? So the interpretation of the FLY trial is that for these low-risk patients, the outcome is likely to be good regardless of approach. Radiation therapy after 3 to 4 cycles of R-CHOP should still be considered to optimize the local control, even if only 3% benefit. We do not want to relapse. These are often older patients and will not tolerate relapse treatment very well. And especially if the disease is slightly on the larger side, but not bulky, because the approach is, of course, different. The late effects are unlikely to be problematic. These are usually older patients, and the treatment fields are usually very small. And you could give the radiation therapy alongside with the rituximab that they're going to have anyway. So, I'd like to stress that it is really also very important, and we haven't perhaps looked enough at this, to minimize the side effects that the patients will have from the systemic treatment. This is a SEER database analysis from the United States, including more than 15,000 patients diagnosed between 1988 and 2004. And this shows the cardiac-specific mortality for patients with stage 1 and 2 diffuse large B-cell lymphoma treated with or without radiotherapy and without radiotherapy. And the lower curve here is for the patients treated with radiation therapy. And as you can see, there's a highly statistically significant increased risk of cardiac death in patients who were treated without radiation therapy, probably because they had more chemotherapy and therefore higher cumulative doses of anthracyclines. So this is a significant risk for these patients, and a reason why we should try to keep not only radiation therapy, but also chemotherapy at the lowest cumulative dose that is still going to cure the patients. For advanced diffuse large B-cell lymphoma, the studies from the German aggressive non-Hodgkin lymphoma group have been really the most important ones, large randomized trials. This was the RECOVER trial, and which randomized patients to 6 or 8 cycles of CHOP with or without rituximab. So no radiotherapy question here. The aggressive non-Hodgkin lymphoma group in Germany have always traditionally given radiation therapy to sites of initial bulk defined as more than 7.5 centimeters or extranodal disease. So that was also done for all patients in this study. And then this strategy has never been tested in a randomized trial, and people, including myself, doubted whether it was necessary. And so at one point in time, they decided in the German group that they would make this radiotherapy optional. And this is what is called a RECOVER North trial, no radiation therapy. It was an amendment, and patients were then treated according to the physician choice with or without radiation therapy. And when they then made an interim analysis of this strategy after the third amendment, they could demonstrate a highly statistically significantly inferior result in patients who were treated without radiation therapy compared to patients who were treated with the standard radiotherapy that has usually used to be used in the German group. So even for overall survival. So obviously the amendment was stopped, and they did the right thing in the German group. They then did a randomized trial testing the use of radiation therapy to initially bulky or extranodal disease in a randomized trial, where you can see here patients were randomized to either CHOP 14 or CHOP 21, and then plus or minus radiation therapy to bulky masses or extranodal disease. And this unfolder study had to be stopped with regard to the randomization of radiation therapy following a planned interim analysis where they could demonstrate that the patients who did not have radiotherapy had a very significantly poorer event-free survival compared to the patients who had radiation therapy. So the randomization to plus minus radiotherapy had to be stopped, and all patients were irradiated after that. But then the question was, do we then need to irradiate all patients who had bulk, or only the ones who did not achieve complete metabolic remission when PET scans were introduced? And this is being tested in the optimal over 60 study, which has been presented at conferences, but has not yet, as far as I have been able to find out, been published as a paper. And this was in the older age group. Typically, that's where most of the patients are anyway, with bulk and with this, either with the risk factors 2 to 4 or bulk. And they were randomized, and no, they were not randomized to radiotherapy, but they were treated with 2 different chemo regimens and with the 2 different numbers of rituximab injections. And then radiation therapy was omitted for bulky disease if it was PET negative. And in this way, 52% of patients, of the patients with bulky disease were PET negative and so received no radiotherapy. So in that way, if you can omit radiotherapy in patients who achieve a complete metabolic remission, you will spare over half of the patients in this patient group the radiotherapy. And they then compared the results to the results of both patients in the Recover 60 trial. You have to be aware here again that they're comparing two arms from two different trials. So this is to be taken with a caveat. And I don't have, as I said, any published results, but this is the presentation from ASCO in 2017, where Professor Franchu presented the data. And you can see here that the patients with bulky disease, if they were PET positive and did not get radiotherapy, the results were very poor. That's the light blue curve down here, both with regard to progression-free and overall survival. If they were PET positive and they had radiotherapy, the results were much better. And I hope you can see that there is a red curve here, just about overlying the yellow curve. That is the patient who were PET negative and therefore did not receive any radiation therapy. And as you can see here, the curves are almost identical, the red and the yellow ones. So the argument was that for patients who were PET positive and received radiotherapy, the results were as good as for the patients who had achieved PET negativity after the systemic treatment. And so this was taken as an argument that it was safe to omit radiation therapy in the patients who were PET negative. The question here is, first of all, they are comparing patients from different trials. Secondly, I would have expected patients who were achieved complete metabolic remission to have an even better outcome than patients who were PET positive after chemotherapy and then had radiotherapy. So the question is, should we be satisfied with the patients who had complete metabolic remission, that they only achieved the same results as patients who were PET positive and had radiotherapy? I think that is an open question. It is not being tested in any of these trials. So the question is radiation therapy to bulk necessary if the patients have achieved a complete metabolic remission after systemic treatment? And we don't have any randomized trials of this. We have retrospective evidence from different institutions and all of them report improved outcome with radiation therapy following a complete metabolic response. So this cannot count as definitive evidence. We really do need a trial to test this, to make sure that complete metabolic response will obviate the need for radiation therapy. As far as it is, the results of the Unfolder study hold, and I think we should stick to that until we have better evidence. With regard to relapsed or refractory diffuse large B-cell lymphoma, I would like to point your attention to, in fact, a whole list of guidelines that have been published by the International Lymphoma Radiation Oncology Group. One of them is on the role of radiation therapy in patients with relapsed or refractory diffuse large B-cell lymphoma. The reference is here, but there is a whole list of guidelines that we published over the past 5 years, taking the issues of radiation therapy in the treatment of different hematological malignancies, which I would like to recommend. For patients who are not in complete remission after first-line chemotherapy for diffuse large B-cell lymphoma, these patients are often offered salvage high-dose chemotherapy if they are fit. We must remember, again, as I mentioned initially and mentioned by Professor Lasker, radiotherapy is an effective treatment with good local control rates in all types of lymphoma, including diffuse large B-cell lymphoma. The question is now, could it be sufficient for patients who have a Deauville 4-5 response? Could we just achieve the same by simply giving them that radiotherapy if they have not achieved complete metabolic remission at the end of chemotherapy? And we don't have a randomized trial on this, but Professor McHale from Guy's Hospital and Dr. Brady from Guy's Hospital in London did this up for the ASTRO 2019, looking at their own patients. they looked at that diffuse large B-cell lymphoma patients treated between 2010 and 19 who had first-line rituximab-containing chemotherapy, mainly 6 cycles of R-CHOP, and who had only achieved a Deauville 4 or 5, most of them 4, fortunately, and who had then received radical radiation therapy, that is 30 gray or more, most of them over 36 gray, because this is active disease after chemotherapy, so expected to be fairly resistant. And this group of patients was fairly typical, wide age range, all stages, most of them stage 2, though, almost half of them. And they were able to irradiate all sites of the disease in more than half of the patients. And the radiation therapy included the initial site of bulk in 3/4 of the patients. And their results are interesting, I think, because they demonstrated here that they achieved actually a fairly respectable progression-free and overall survival in these patients, with more than 50% of patients achieving what seems to be durable remissions after just radiation therapy in this situation. And they looked then at the predictors of outcome to see which patients this approach could be appropriate. First of all, the patients with Deauville 5 had a much higher risk of progression than the patients with Deauville 4. So the Deauville 4 patients clearly are more appropriate for this treatment. And of course, if the patients were still Deauville 5 after radiotherapy, it was simply not going to go well at all. And if they were able to irradiate all initial sites, that is, the disease was so localized that they were able to include all of the involvement in their radiation volumes, then they had a much lower relapse rate than if they could not. So patients who seem to be doing well with this approach would be patients who have a Deauville 4 residual disease after chemotherapy, and where you can irradiate all initial sites. Whereas stage, IPI, presence of bulk, and radiation dose within the limits they were given were not significantly associated with relapse. So this is just food for thought, that in patients who have not achieved a complete metabolic remission after full systemic treatment are still in a certain percentage curable by simply giving the radiation therapy after the systemic disease. So there are a number of future roles for radiation therapy in diffuse large B-cell lymphoma that are important. First of all, the one that I just mentioned, namely that you shouldn't discard it as a possibility of achieving complete remission in a patient who has not responded sufficiently on systemic treatment. Another area which is very hot at the moment is bridging to CAR T-cell therapy. This has been already published quite extensively and being now possibly exploited also for perhaps finding some way of using radiation therapy as an augmentation of the effect of the immune therapy with the CAR T cells. The bridging for CAR T cell therapy is quite often very important in that situation, because many patients are chemo resistant and many patients are progressing rapidly, and they have to wait for, I suppose, 4 to 6 weeks for the CAR T cells to have been produced, and that period of time they may simply not be able to keep the disease at bay unless radiation therapy is used, because radiation therapy can still have a high response rate in these patients and control symptoms and hold the disease, reduce the bulk, and may possibly reduce the CAR T cell toxicity as well. And this immune priming, which is now being tested with very low doses of radiation therapy in this situation. So the optimal timing, dosing, etc., need to be defined, but it's an interesting area with the very promising results of the CAR T cell therapy that we're able to enable patients to get to actually that treatment by using radiation therapy in a smart way. the problem is, as mentioned previously by me, also by Professor Lasker, that there's been a scare of radiation therapy. It was based on the long-term side effects of the large volume and high-dose radiation therapy, which I showed you at the beginning, and which is no longer used, hasn't been for 15, 20 years. The limited and highly conformal and personalized radiation therapy has reduced the risks dramatically. And we need, of course, to have long-term data on this, but we do have, they're beginning to appear, but we also have dose response analysis with dose response data from the old days that we can apply to modern treatments and extrapolate to estimate the risk of long-term complications, even if we don't have yet the long-term follow-up. So the risk of radiation therapy should really be evaluated in each individual case, because as the treatment is now highly personalized and tailored to each patient's exact disease extent, this is not something that you can just estimate on the basis of large population data. You need to evaluate each patient at his or her own merit. And then the risks should be put into perspective, should be weighed against the risks of systemic treatment and weighed against an increased risk of relapse, and also weighed against the risk of then, if a relapse occurs, the added intensive treatment that is needed and which is in many patients simply not tolerable. The major concerns have been second malignancies and cardiotoxicity, which have been the main causes for added mortality and long-term follow-up from the old large field radiations. And I'd like to point your attention to a recent Danish study, which was published in JAMA Oncology in 2019, where the authors used the excellent nationwide Danish health registers, which are fairly unique. We have a personal identifier for each person in Denmark, so we can follow them in all the different health registers and then analyze their morbidities and mortalities and reasons, medicine and so on. And in this project, they looked at patients who were over 40 years at diagnosis, and they looked at different malignancies, but these are the data for non-Hodgkin lymphomas. And they then looked at the risk of being hospitalized for different types of diseases, and whether that was above the risk of the normal population. And as you can see, patients who've been treated for non-Hodgkin lymphoma have an added risk of being hospitalized for infections and for blood diseases, for endocrine system and so on. But there's no increased risk of being admitted to hospital for a second malignancy. And this is actually in accordance with the many other studies that have demonstrated that the risk of a second malignancy is really a risk that you see in young patients. It is very relevant for patients below the age of 40. But in these patients over 40, this is not a significant risk in older patients. The scare of second malignancies is something that you should definitely think of in young patients. But in patients over the age of 40, this is not a concern that should influence your treatment choice. This is also another interesting study, which is really quite puzzling and thought-provoking, is a study from the Netherlands, published in New England Journal of Medicine in 2015. I don't know if you noticed it, but it looked at second malignancies in a Dutch cohort of patients treated for Hodgkin lymphoma in 3 different time periods: 65 to 76, 77 to 88, and 89 to 2000. And in this period, the use of radiation therapy and the treatment fields decreased very significantly. So a decreasing use of radiation therapy, fewer and fewer patients got radiotherapy, and the treated volumes became smaller and smaller. And conversely, the use of chemotherapy increased during this period of time. These were still old-fashioned radiation fields. It was not modern, highly conformal, but it was simply the use of it, and that was very significant. The interesting thing is that the cumulative incidence of any malignant neoplasm or any solid malignant neoplasm was exactly the same during all these 3 periods. These curves show the different time periods, the cumulative incidence of malignant neoplasm, and the dotted lines down here is the background, the risk of the background population. And the striking thing is that you would have expected to see a decreasing risk, at least of second solid malignancies. In fact, it was a bit lower in the beginning, and that's the time period when the chemotherapy gave early menopause for female patients, which decreased the risk of breast cancer. So that is kind of artificial, and you shouldn't think too much of it. But the strange thing is, and this is quite still puzzling, why is it there's no difference in second cancers when radiation therapy is decreased and chemotherapy is increased? We had expected it to be decreasing when radiation therapy use was decreased. And the reason can be several. First of all, chemotherapy may be more cancerogenic than we thought. But only now we are getting large cohorts of patients with 20 to 30 years of follow-up appearing who have had chemotherapy alone. And we have perhaps also shown less interest in analyzing the long-term consequences of chemotherapy. We really ought to do that, because that is information we need to weigh different treatment options. And secondly, the mechanism behind the secondary cancerogenesis may be more complicated than the direct induction of DNA damage leading to somatic mutations. Now, I don't doubt that ionizing radiation leads to somatic mutations leading to cancer, but there may be other factors at play also. First of all, the genetic susceptibility and the DNA repair defects may play a role in different patients, and perhaps even more importantly, the immune system. With the immune suppression and with systemic chronic inflammation playing a role. And when I showed these data to my infectious medicine specialist colleagues, they said, well, this is exactly what we would have expected. That's what we see in our HIV patients, an increased risk of solid tumors. So I think we need to analyze this in more detail. It is not the radiation-induced damage alone that we need to take care of here. With regard to heart problems, we have some good analysis from the collaboration between the Dutch and the British group in Oxford, where they've looked at a dose-response relationship for different cardiac complications. And this curve shows an analysis from that group where they were able to deduce a dose-response relationship for coronary heart disease as a function of the mean heart dose from radiation therapy. And we know from the old days that a mantle field radiation therapy would, on average, give about 20 Gray of mean heart dose. That was the old extensive fields. With modern radiation therapy, it is, of course, a lot more varied, but in large cohorts of patients with mediastinal Hodgkin lymphoma, the dose to the heart with modern involved site radiation therapy is on the average well below 5 Gray. So you can see now that modern radiation therapy is expected to give a much, much lower risk, added risk of heart disease compared to the old-fashioned mantle field, the old-fashioned extended field. So this is just to put into perspective what we are doing with, probably doing with modern radiation therapy. And this is also borne out by these curves, again from the Dutch group, where they showed the cumulative incidence of coronary heart disease. And you can see this is the old-fashioned mantle field to 25 Gray, 20 to 24, 15 to 20. And then now we're down at the level of the modern treatments with involved node and involved site radiotherapy to lower doses. And you can see that the risk is considerably lower. With regard to valvular heart disease, that is actually a serious problem. It occurs later than coronary heart disease, but it's actually more common than coronary heart disease. And the Dutch-British group were able to deduce this dose-response curve for valvular heart disease, which is not a straight line. It is very flat at low doses, and then it becomes steeper and steeper when we get to higher doses. And when we look at the doses that were given in the old days, then if we look at the aortic valve, which is the most important one, the mantle field radiation would give the same dose as the prescribed dose. So we put it here, 36 gray. It may even have been higher in many institutions. And with modern radiation therapy, we know from a cohort of patients we have analyzed that the mean dose to the aortic valve is just a little above 15 gray. So this is typical of a modern population. And as you can see, with modern radiation therapy, we are down to a dose where we are almost not even above the risk of the background population. So again, modern radiotherapy is reducing the risk very significantly for the cardiac problems. And this curve, again from the Dutch-British collaboration, demonstrates that the cumulative incidence of valvular heart disease is much higher if you go to doses over 40 gray, obviously, 36 to 40 gray or 31 to 35 gray, whereas if you keep down to the lower level that we're doing today with the conformal treatments, we are much, much lower down than we were in the past. And then this was a study that group did on the risk of heart failure. And here you can see that the dose response curve that they deduced from the data available demonstrated that the curve was very, very flat at low doses, and then it became extremely steep at higher doses. But in the dose ranges where we operate in lymphomas, we're actually down to the very flat area, both with the old-fashioned and the modern treatment, which illustrates that heart failure is really not an issue with the radiation therapy. The heart failure that you see in increased risk in lymphoma patients must be attributed to the anthracycline dose, the cumulative anthracycline dose, which is causing heart failure. So this is not an issue with the radiation therapy. And this is borne out by these curves, again, from the Dutch group, where you can see that, and they don't explain it very well, but the full lines are the curves for patients who receive both radiation therapy and anthracyclines. And you can see a high dose plus anthracycline is, of course, absolutely the worst. Lower doses plus anthracycline, less so. And the patients who hardly got any radiation dose is still anthracyclines up here. Whereas the patients who had radiation therapy but no anthracyclines had much lower risks. So obviously, the risk of heart failure is very much attributed to the anthracyclines, which also simply goes to show that we need to keep all treatments at the lowest cumulative dose, but of course still cure the patients. And this curve also demonstrates it very nicely. The yellow curve shows the cumulative incidence of cardiovascular disease in patients who had mediastinal radiotherapy and anthracyclines. The green curve is patients who had mediastinal radiotherapy and no anthracyclines, and the blue curve is the patients who had anthracyclines but no radiotherapy, and the lower curve here is a no mediastinal and no anthracycline curve. So it is the combination, and we should try to minimize all of the factors that are causing long-term complications. We looked at all the randomized trials that the EORTC LISA group, the French, the EORTC and the French group had done together in Hodgkin lymphoma. So we had a total of over 6,000 patients who were randomized, and where we were able to reconstruct their radiation doses to the cardiac structures and their cumulative anthracycline and cumulative chemotherapy doses. And so we looked at those and looked at cardiovascular disease, simply a cardiovascular event after the treatment. We used both the follow-up of the patients in the database and also a questionnaire that had been sent out to patients. And the interesting thing is that we could deduce from this by multivariate analysis that the two factors that were important for a cardiac event later on was the mean dose to the heart and the cumulative dose of anthracyclines. What we could also see is that the curves that we could develop from this, up here is the curve, the hazard ratio as a function of the mean heart dose of radiation therapy. It was approximately a straight line, as you can see here. And down here is the hazard ratio as a function of the cumulative dose of anthracyclines in milligrams per meter square. Again, an almost straight line. And what we could also see is that an increase in mean heart dose of 5 gray yields about the same excess risk of cardiac event as an increase in the cumulative anthracycline dose of 50 milligrams per meter square. Now, 50 milligrams per meter square is what you give by 1 cycle of ABVD or 1 cycle of CHOP. So you can see that if you increase the number of cycles just by 1 of the anthracycline-containing chemotherapy, you will increase the risk of a cardiac event by as much as an increase in mean heart dose of 5 gray. And as you may remember, a mean heart dose of 5 gray is actually, in modern treatment, that is actually, well, the mean dose that we normally achieve is less than 5 gray. That's actually our aim. So you shouldn't increase your number of cycles of chemotherapy by more than 1 or 2, and then you may have to avoid radiation therapy, and then you may have actually increased rather than decreased the risk of cardiac complications. So in conclusion, we need to titrate the intensity of all treatment modalities to achieve an optimal trade-off between risk of serious side effects and chance of long-term survival. This is an article that we are working on at the moment because we're trying to develop tools, mathematical tools, to take into account in lymphoma, in treatment of lymphomas, the lymphoma subtype, the anatomic location, disease extent, response to systemic treatment, tolerance of normal tissues, and patient age, sex, comorbidities, and of course also patient preference. So by this, I'd like to end my talk. Thank you for your attention. I'd like to just introduce to you, or to mention again, the International Lymphoma Radiation Oncology Group. It's a worldwide group of radiation oncologists, especially interested in hematological malignancies. And I'd like to encourage you, all of you, I'd like you to mention that to your radiation oncologists if they're not here, that they should join this group. It's completely free. You just go to our webpage and register, and it gives a lot of, I think, valuable information for radiation oncologists doing lymphomas. We published all our guidelines there. We publish and we present our presentations, and we have even now started doing YouTube videos of teaching sessions that have been done by ILROC, and this is to be found there all for free. And finally, I'll mention that I do a course on hematological malignancies, radiotherapy of hematological malignancies, in collaboration with ESTRO, the ILROC ESTRO School of Hematological Malignancies. We were supposed to have done our 4th course in Lyon in this spring, very soon actually. It is very, very sad that we are not able to do it, but we are doing it now as an online course from the 18th to the 21st of April, taking you through all the different disease entities and the role of radiation therapy and the techniques and so on. So I just advertise this for anybody interested. We have had Indian colleagues on the courses before. So thank you very much.
Thank you, Dr. Lena Speck. That was a wonderful talk. You touched upon a lot of gray areas and replied with evidence-based medicine. I think this must have benefited almost, we have 400 people who have logged in to listen to you, and they all must have benefited a great deal. We have a large number of faculty here who also have certain questions they will be asking you. Just we start that, before that, I will just give the answer of the quiz that we had this morning. So just get that out of the way in 2 minutes. You can see my screen?
Yes, sir.
Okay. So the question was that there was a middle-aged female patient who had lost her vision, and she had chest and abdominal discomfort. In the blood counts, there was high platelet count, 1.2 million, everything else was normal. We had shown you the CT aortogram and fundoscopy. That was the CT aortogram. What you see over here is the aorta, thoracic aorta, and you see some filling defects over there, multiple large filling defects. And then that was the abdominal part of it, once again, large filling defect through and through. So thoracic and abdominal aorta with large filling defects. And that was the fundus picture that was shown to you. You could appreciate large number of abnormalities, which I will describe to you. So what the CT aortogram has shown is the multiple thrombi in the descending and abdominal aorta. And we pointed that out to you. And what this fundoscopy shows you is that there is a disc edema. The arterioles are severely attenuated. There are dilated tortuous venules, the veins. There's extensive superficial and deep hemorrhage. The retina is overall pale, and there is a cherry red spot in the macula. And the conclusion was that this patient has essential thrombocythemia with a platelet count of 1.2 million, which has led to a large thrombi in the aorta and similar thrombi in the retinal vessels, leading to hemorrhages. So that was the final diagnosis. Over 40 people have tried to answer the questions, and the first correct answer is from Sri Lanka, Dr. Thanuja Disanaike. So congratulations to you, Dr. Thanuja Disanaike, and we will send you your gift. So that was that, and now we go back to our faculty from India who will be asking questions to Dr. Lena Spett. We begin with Dr. Shyam Agrawal.
Actually, I had you sent me the questions yesterday, so I prepared some slides. But now I seem to have come off. Can you hear me?
We can hear you.
Yeah, but I can't see you. I don't know whether that matters, or if you could help me to get back to the.
You want to go back to your slide?
To see you again. And then I could share my screen because I prepared my screen to be shared. But
okay, Pankti, can you help her? She's not able to see us.
Ma'am, on the taskbar there is the Zoom icon of the Zoom. Just click on that.
But that says either Zoom Cloud Meetings or Zoom. Which one should I choose?
The Zoom one meeting, ma'am. Are you there?
I did that, but it doesn't change it.
Okay, just ma'am, click Alter tab.
Pardon?
Alter tab, ma'am. And there will be the Zoom option there.
I have clicked the Zoom option, but it doesn't come up. Can you do something from your side?
No, ma'am. Actually, it's your system. Ma'am, just have you put your slides in a slideshow mode? Just minimize that and then come to Zoom.
I can see your Pankti but I can't get on. Actually, it doesn't matter because I don't need to see you. So we can just take the questions without that. If you could, but I need to share my my presentation with you, don't I?
Yes, ma'am. Ma'am, just come to the taskbar. There is a Zoom icon. You have to just click on that.
Yes.
There will be the two options, Zoom Webinar and Zoom iCloud Meeting. Just you have to click on the Zoom Webinar.
It doesn't say Zoom Webinar. It says Zoom simply. Do you think I should? But it is open. Otherwise, we couldn't talk to each other.
Maybe you can share your screen again. Just stop sharing and then share again.
Yeah, but I can't. I don't get to the icon of sharing the screen.
Okay, ma'am, can you see my icon?
I can see you.
Okay, yes. Just click on that.
Click on the camera or what?
Just there will the icon, the third one icon. Just click on that.
Which icon should I have? A microphone, a camera, and an arrow?
No, ma'am, not that one.
I can see your Pankti, but I can't.
You can't see us.
No.
Elena, you are able to hear us?
Yes, I can see you, Mohan. It's just that you haven't got my slides, so you can't see them. Should I go out of this and enter again?
Yes, I think that's the option.
Yeah, probably. I'll do that. I can even hear the streets of Mumbai.
Ma'am, just minimize your slides.
I've done that, and I'm going to enter the link again.
Dr. Lena, please connect with the audio. Ma'am, can you hear?
Yeah,
Yes,
you can see me and hear me, and now I will share my screen. Here it is. Can you see it?
Yes, ma'am.
And then I'll just make it a slideshow, because then I hope if we take the questions in the order that you mailed me yesterday, I will have some responses that will help us discuss this. So please, sorry about this. We can go on with the questions.
So whose question was this?
Hi, this is mine. This is Dr. Padate from Hinduja Hospital.
Yeah, please.
So we got a 24-year-old MBBS female student who presented with cough, respiratory symptoms, and finally was diagnosed to have primary mediastinal lymphoma. She was treated with R-EPOC, DA-R-EPOC, and was in remission, metabolic remission at the end of 2 cycles. She went on to continue 6 cycles and also had intrathecal 4 injections of methotrexate. She remained, at the end, she had a repeat PET scan which shows metabolic remission. However, she had 1.8 centimeter scar tissue at the site of the primary mediastinal lymphoma. She remained well for like 8 weeks or so and started having cough again after completion of chemotherapy. And then we repeated a PET which showed activity at the site of the scar. So she had a CT guided biopsy which showed the high grade lymphoma again, and received 20 fractions of radiotherapy over 5 days. So my questions are, has radiotherapy improved progression-free survival and overall survival in patients with primary mediastinal lymphoma? And second question is, considering R-EPOC, DA-EPOC as the standard of care in primary mediastinal lymphoma, what is the role of radiotherapy during first-line therapy?
Yeah, well, first of all, very good questions. I don't think I have a clear answer to that. I'm sure you would know if there was. Obviously, this is a fairly rare disease. We don't have any randomized data on the role of radiotherapy yet. We are awaiting the IE-LSG 37 trial, which is randomizing patients to plus minus radiotherapy. But I think they've stopped accruing, but I haven't seen any results from them yet, not even at conferences. Now, these patients usually have early stage and bulky disease, and with R-CHOP alone, the failure rate is unacceptable. And we always give radiation therapy to these patients if they're treated with R-CHOP, because they don't tolerate the EPOC or whatever. But with the dose-adjusted EPOC plus rituximab, as you gave your patient, the relapse rate is very low, was very low in the initial publications. And so radiation therapy seemed to be unnecessary if the patient had achieved a complete metabolic remission, as your patient had at the end of therapy. As I said, we don't have any randomized trials. You clearly did the right thing because you gave the patient the radiation just, these 4 months later, but you took the chance of using radiation therapy at that point in time, which I think was very smart. And the patient clearly is in durable remission now. So that's great. Congratulations on that. Radiation therapy is highly effective in converting a partial remission to a complete remission. And the end of radiotherapy chemo treatment PET has a poor positive. That is the positive predictive value of a PET scan after chemotherapy in these patients is actually rather poor. But you have a biopsy, so you know that this was a relapse, residual disease. But often if you do a biopsy, you will have a negative result. The problem is, will you believe it or not? Because it is just a sample, and you may have missed the active disease. In the SEER analysis of 250 stage 1 to 2 patients with primary metastatic B-cell lymphoma, they demonstrated that clearly there was a superior overall survival in patients who had received radiation therapy. These are not randomized, so there might be all sorts of biases in this. I certainly believe that radiotherapy is a modality that gives you a high local control if you need it. You clearly need it if you use CHOP as your backbone. You are not supposed to need it in patients treated with the more intensive regimen of dose-adjusted EPOC plus rituximab if you achieve a complete remission on PET. But on the other hand, I have to say that we don't have many of those patients at my institution. I know from my colleagues in other centers around the world where they have more of them that they are not that positive about the dose-adjusted EPOC regimen because they do see quite a number of recurrences where the patients would really need radiation therapy. I do believe that radiation therapy, as it is a potent modality, will improve results. We just need to do it in a smart way. We hoped that the dose-adjusted EPOC would obviate the need for radiation therapy in many patients. They're often quite difficult to radiate because they have very large disease. But your case here, and also the experience in many other centers, is that you do actually need it more often than perhaps you thought from the initial EPOC publications. I don't know
Dr. Lena, I'll take 30 more seconds of you. So I'll give you an update on this patient. Subsequently, this girl went on to do a pediatric rotation, postgraduate rotation, completed that, got married, and has a 1-year-old baby now. She remains in complete remission, no further treatment. So now the question is that, would you recommend doing serial preemptive mammographies in such patients? And EPS, then what age you would start?
You need to look at the dose plan of that patient, but very probably she had some dose to her breast tissue. Correct. But I think for these follow-ups with modern radiation therapy, which is done so individualized and conformal, you will need to know what organs actually got a dose. But very likely her breast tissue will have got some dose. We advise patients with early stage Hodgkin lymphoma who've had radiotherapy and where the breast tissue has got some dose to start mammography screening 10 years after they've had their treatment, and to continue that for as long as mammography screening is advised. And we only advise this for patients who are treated below the age of 30. If you get much above that age, you can't see any increased risk of breast cancer. It is really a problem of the young, but she was young, and I certainly would advise her to get what we call clinical mammography, where you do both a mammogram, an ultrasound, and a palpation. But I also advise them to find out when the time comes, because that's 10 years from now, if that is the advised screening program, because MR scans may become more popular and more relevant in the future in these young patients. But
Thank you.
That's what we would do.
Thank you, Dr. Lena.
Thank you.
Dr. Lena, can I take intermittently questions from the audience who are present today?
Yes.
So Dr. Roshni Pandey wants to know, in which case of Hodgkin lymphoma in females do you justify the use of mediastinal radiotherapy?
Well, if we take an early stage Hodgkin lymphoma patient, we know that the risk of recurrence is increased if we don't use radiation therapy. And so I discuss it with the patient. I look at the treatment plan. First of all, we try to keep the dose to the breast, the mean dose to the breast, less than 4 gray. That is, for virtually all solid tumor risks, the response relationship is a linear one. So increasing the dose leads to a direct increase in risk, which also means that if we can keep the dose to the structures very low, then the risk will be very low. And we, with the advice on mammography screening and so on, we know that, and with the very fortunate increased, significantly improved prognosis of breast cancer. What you also need to take into account is what if this complication should occur, what is then the risk of it? How dangerous is it? And we know that the prognosis of small breast cancers detected earlier by screening, as will happen in these patients, have a very good prognosis. So I'll discuss that with the patient and consider that as opposed to the risk of a relapse and what that will incur with respect to it's usually high-dose chemotherapy and autologous stem cell transplant with a very significant increase in risk of long-term complications, infertility, and so on. I will then put that to the patient. I can tell you, but that may differ from country to country. But in my country, virtually all of the patients prefer to have the highest chance of cure and prefer us to do the radiotherapy with as low a dose to the breast as possible, and then to use the screening program. So I take that discussion with the patients, and I must say that most patients choose to have the highest chance of cure and then to do the screening program and have that very small risk 15, 20 years from now, our disease that has already now a very good prognosis.
Thank you. You can take the next question sent to you.
What is the next question?
You have the next question on your slide?
Oh, sorry.
Right.
Question 3.
Whose question is this?
This is the question number 3 from your list. In a young patient with relapsed diffuse large B-cell lymphoma.
Yes, ma'am. So, hi, ma'am. Good morning. This is Dr. Satish here, hemato-oncologist. So this is a young patient, in fact, 35-year-old lady who had DLBCL somewhere in 2014, treated with 6 cycles of R-CHOP. Unfortunately, after 6 years, she had a relapse, and it was an aggressive relapse, stage 4 relapse. It was not double hit or double expressor. So this patient received salvage with 2 cycles of chemotherapy or GDP, and post 2 cycles, she had paravertebral soft tissue at around L4, L5. We gave 1 more cycle of salvage, but that disease still persisted. It was low-grade SUV. I'm not sure what the dual score, but it was a low-grade SUV around 3 or something like that. So we went ahead with autologous stem cell transplant. Post-transplant, the PET scan is in remission. But after listening to your talk, I think you did a quote about ASTRO 2019. But I wanted your opinion regarding such patients post salvage if they have a small residual disease? They are chemosensitive, they are in near complete remission or good partial remission. What do we do with those sites? Should we give RT post transplant or before transplant?
Well, first of all, I'd like to ask, the patient hasn't been irradiated before, no?
No, not really.
No. And I'd like to draw your attention to the guidelines that I mentioned also in my talk on relapsed refractory diffuse large B-cell lymphoma, which we published from the ILROG with Dr. and Professor Ng from Harvard as first author 2 years ago. And in that, which I can recommend to you, is got a very detailed review of the situations that you face. And our general indications for radiation therapy in relapsed diffuse large B-cell lymphoma is, of course, to localize relapse that can be encompassed by a radiation volume that will increase the chance of a permanent cure. For disseminated relapse in sites that were bulky at relapse, I don't know if this was really bulky or not, but to local regionally confined site with an incomplete response to salvage chemotherapy, and that's actually what you have here, isn't it?
Yes.
And then to dominant skeletal involvement, because there's some indication that that is particularly resistant to chemotherapy. And then the other point, which is also relevant here for you, is that this is a site in which local control is especially critical because it's close to the spinal cord. And this is a site where you do want to achieve permanent local control in order to avoid spinal cord compression. So yes, I think there are two good reasons why you should choose to irradiate this patient. And as this patient has active disease, it's positive on PET scan, I would go to a dose of 40 gray. I must stress that, first of all, this patient is young, but in a relapsed situation, the concerns about long-term complications gets much more relative, doesn't it? Because here the patient is at a real risk of dying from the lymphoma long before the long-term side effects. And with regard to the timing, then there are pros and cons of different, of either doing a pre-transplant or post-transplant. And I think there are different schools here. For pre-transplant, well, of course, it achieves a more cytoreduction by giving the radiation therapy before. And you are not irradiating the transplanted cells, which is also an advantage. And I think this is the approach that they are advocating at Memorial Sloan Kettering Cancer Center. On the other hand, doing it post-transplant, it may be even smaller volumes that you need to irradiate, may have shrunk even more, and there may be less toxicity. I think this is the approach that they have advocated at Princess Margaret Hospital to avoid lung toxicity. This was in an area where you might have also given some lung dose, so that would be an argument for doing it afterwards. So I don't think there's a clear-cut answer to what is best. Personally, I actually like the idea of doing pre-transplant, in order not to irradiate the transplant.
So we did go ahead with the high-dose transplant, and she's in CR, and at present she's receiving radiation. We discussed in the tumor board, and same guidelines we thought, because right now the radiation oncologist suggested 24 gray to that area, so she's going ahead with the radiation at present.
Okay, fine.
Thank you so much.
Thank you. We'll take up one more question from the audience. There is a question from Dr. Shishank. What is the role of radiotherapy in retroperitoneal DLBCL, and what will be the dose?
In retroperitoneal?
Retroperitoneal diffuse large B-cell lymphoma.
Yes.
What is the role of radiotherapy and what will be the dose?
Is it a localized diffuse large B-cell lymphoma with no other disease anywhere? In that case, I would certainly advocate first R-CHOP, and if it's a large mass, full 6 cycles of R-CHOP, and I can encompass the whole area with my radiation field, so I would do that to 30 gray in a situation where I've achieved complete remission with chemotherapy. They usually are quite bulky, aren't they, in the retroperitoneum? And they have this unfortunate tendency of being located right between the kidneys, But with modern radiation therapy, we are always able to avoid the kidneys.
And the second part of the question was the dose.
If the patient has had chemotherapy and has achieved a complete metabolic remission, I would give just 30 gray.
30. Thank you. We can go for this question. Whose question is this?
It was the same. I think I asked the same question, but I think you answered in the first question, ma'am.
Oh.
The 14 primary media cell billion cell.
Dr. Lena, you can go for the next question.
Yeah. So that was.
Yeah.
Relapsed refractory lymphoma, wasn't it?
Okay. And the next one?
And then the current role of radiation therapy in advanced stage high-grade non-Hodgkin lymphoma. Isn't that the next question? Is somebody wanting to expand a little bit on that?
Whose question is this, please? Indian faculty, please. Whose question is this?
Yeah, I guess this was my question, but Madam has described it very much in detail in her presentation. But if she could like to summarize again, it is fine.
Okay.
Yes, the unfolder study demonstrated that you do, in fact, achieve a better outcome by irradiating the initial bulky or extranodal disease. The optimal study then suggests that you can do this only to patients who are not in complete metabolic remission, so you can do a PET-adapted treatment. As I mentioned, I'm not totally convinced that this is shown by the optimal data, but the optimal data haven't been published so that you can really study the data. They've only been presented briefly at conferences. So I use the data from the unfolder study mostly, and we participated in that trial. So the definition of bulk is 7.5 centimeters, and extranodal is a very complicated thing that they have defined in the protocol, which is not exactly what we would call extranodal disease. But I think the most important part is the bulky disease. And in the protocol, we use 36 gray, so that's what I'm using.
For the extranodal disease, not in CMR, what dose would you recommend?
If the patient is not in CMR, then the patient, when you take them to radiation therapy, that you then have active disease. You must assume you have active disease. And in that case, I'll go to 40 gray. I don't have any data to indicate that less is enough for that.
Thank you, Madam.
Thank you.
Thank you. We'll take up one more question from the audience. Dr. Giridharan wants to know about the Deauville score, especially the interpretation of Deauville score 3 and 4.
Yes, I think it's getting more and more clear that Deauville score 1, 2, and 3 are complete remission. And it's only Deauville score 4 and 5 that are indicators of active disease. And that has been shown both in Hodgkin lymphoma, where the German group had actually used 3 as also an indicator of active disease. But when they looked at the data, it was only the grade 4 and 5 that were really having a poor prognosis. And I think the same has been also shown for the from the aggressive non-Hodgkin lymphomas. So we use or we regard 1, 2, and 3 as complete metabolic remission.
Thank you. Dr. Elena, you can take your next slide. Okay, whose question is this, please?
Refractory classical Hodgkin lymphoma.
Anyone over here? Okay, ma'am, you can go ahead with the discussion.
Okay. Well, the question was, what are the factors to be considered for radiation therapy in refractory classical Hodgkin lymphoma? For limited volume disease, then the indications. In fact, I'd like to also here to draw your attention to the IROC guidelines. We also made guidelines on relapsed refractory Hodgkin lymphoma. First author Sandy Constein from Rochester, and the indications here are for limited volume disease, which can be encompassed in a radiation field. That is an indication, obviously, and to achieve remission. And for more disseminated disease, again, we would include or advise to include radiation therapy in the overall treatment. The overall treatment will very often, of course, be high-dose chemotherapy and stem cell transplant. But we would advise to give radiation therapy to persistent FTD avidity after conventional dose salvage or autologous stem cell transplant, to primary refractory disease with a distribution that allows radiation therapy if you can encompass all of it in the initially refractory disease. And then again, like we discussed for diffuse large B-cell lymphoma, to sites where local control is especially critical, in particular with the superior vena cava compression or spinal cord compression. In that case, we will irradiate those areas to make sure that we have at least permanent control in that area. So these are the indications that we would give for radiation therapy in refractory Hodgkin lymphoma.
Thank you. I'll take one more question from the audience. Dr. Nidhi Jain, what is the role of radiotherapy in a case of brachial plexus involvement by Burkitt's lymphoma, patient not responding to high-dose methotrexate-based therapy? And
where
also,
was the location?
Brachial plexus is involved by Burkitt's lymphoma.
Yes.
And has not responded to the high-dose methotrexate-based chemotherapy. Is there a role of radiotherapy, and what will be the dose?
Well, that is a difficult question. Normally, for the highly aggressive lymphomas, radiotherapy plays a very minor role. These are treated with the very intensive chemotherapy, but we do, in certain situations, have a role in the radiation therapy. It's particularly in situations where you need to achieve local control and the disease is refractory to the systemic treatments. And so I would discuss this very thoroughly with the treating hematologist and find out where do you need to achieve local control. If so, obviously we'll give it. When I do that, I go to fairly high doses because I have no large randomized data on these patients, obviously. And on the other hand, it often is a question of getting it done fairly quickly because the patient needs to get on with more chemotherapy. So what I often do is that I hyperfractionate them. I give them 2 fractions per day to accelerate the treatment and to get to a dose of 36-40 gray fast. But I think radiation therapy is just an adjunct here that can help you get local control in an area where you really need it ASAP.
Thank you. Dr. Lena, you can go to your next slide.
Yes. It's on mediastinal nodular lymphocyte predominant Hodgkin lymphoma. Somebody asked that question. I would like to hear if...
Is the faculty here, the one who asked this question? I think, ma'am, you'll have to go ahead.
Okay. Because it's considerations during treatment of mediastinal nodular lymphocyte predominant Hodgkin lymphoma. First of all, my question would be, is it really nodular lymphocyte predominant Hodgkin lymphoma? It is very rare that nodular lymphocyte predominant Hodgkin lymphoma has mediastinal involvement. In fact, what I've found is that if I then press my surgeons to do a biopsy, they will often find that it is a different histology in the mediastinum, more like nodular sclerosis or something like that. I would be very cautious to accept a diagnosis of nodular lymphocyte predominant Hodgkin lymphoma in a mediastinum. But if I had to accept that is the dose, I would then consider other risk factors that would justify combined modality therapy. For instance, that you treat nodular lymphocyte predominant Hodgkin lymphoma if it's localized with radiation therapy. If it is not localized, if it's in 2 regions that are not neighboring regions, I would treat it as with combined modality therapy like I would with classical Hodgkin lymphoma. And in this case, as I very much doubt the diagnosis, I would try to find some reason for giving combined modality therapy.
Right. One question from the audience. Dr. Neeraj Dhingra wants to know, what is your take on radiotherapy in follicular lymphoma after chemotherapy?
So you mean follicular lymphoma, systemic disseminated disease?
Looks like that you have given, say, all the cycles of bendamustine, rituximab, or R-CHOP. Now, yeah.
Okay, I would consider doing radiotherapy if you haven't achieved a complete remission in some areas. But on the other hand, if it's disseminated disease, you're not going to cure these patients. And if so the radiotherapy in this situation is only palliative, and so I would actually advise against giving radiation therapy unless the patient has some kind of symptoms from a mass that is giving compression or other kinds of symptoms. If it's asymptomatic, I would not advise having radiation therapy. I don't think the patient needs it.
Right. Dr. Sairam wants to know, as you are using very low doses of radiation nowadays, can the same area be radiated again if there is again a recurrence?
Yes. The short answer is yes. Now, if we're talking about indolent lymphomas, today for palliative treatment, we're actually using just 4-gray, and you can do that several times. It's amazing how much local control you get. So usually what the problem you're facing is not giving re-irradiation, but giving radiation to some other part, because the patient really likes having the symptoms controlled without any side effects. But also if you go to aggressive lymphomas and to Hodgkin lymphoma, with modern techniques, you are usually, if it's really needed, you're usually able to re-irradiate the same area to a curative dose, because we are able to distribute the dose within the patient so that we avoid the critical structures. We can get around the spinal cord and so on. So in many cases, most cases actually, we're able to deliver reasonable radiation therapy as re-irradiation. The question is it a good idea or not? Because if the patient has failed already curative treatment in the first place, is it then likely that we will achieve durable remission a second time round? But it is possible technically in most cases.
Thank you. Ma'am, you can go to your next slide.
So, nodule lymphocyte predominant Hodgkin lymphoma, dosing, margins, and fields. Yes. Somebody wants to elaborate on the question?
Whose question is this? Once again, I think.
Okay. Well, for the in fact, the guidelines that we published back in 2014, the first guidelines from ILROG on radiation therapy for Hodgkin lymphoma, also has a section on nodule lymphocyte predominant Hodgkin lymphoma, and we advise a dose of 30-gray. We haven't got randomized data on this, but it seems to work very well. We have published a large series of early stage nodule lymphocyte predominant Hodgkin lymphoma in blood just last year. Binkley was the first author, and we have very good local control. But the margins and fields in this situation, it is still involved site radiation therapy, but as we are not giving any chemotherapy, we need to, so we use involved site radiation therapy, but the CTV should include not only the GTV, but also as a minimum, and is that I just quote from the guidelines, adjacent lymph nodes in that site and a generous margin dictated by the clinical situation. So it's the same situation as for follicular lymphoma, because both nodule lymphocyte predominant Hodgkin lymphoma and follicular lymphomas are indolent lymphomas treated with radiation therapy alone, and you need to think what are the likely microscopic lymph nodes that you might find in this area. And I'm afraid I can't give you any more distinct guidelines on this, because it is a question of where the anatomy is where it is located anatomically and what areas you would like to include. I have included here an example from actually from Dr. Michael from our course, where you can see a patient with nodular lymphocyte predominant Hodgkin lymphoma with a clinical stage 1A in the right neck. And you can see over here that these are the macroscopic lymph nodes. You can see them also here in the coronal section and the sagittal section. And the red area is what he has included as the clinical target volume. As you can see, he has included all the adjacent lymph nodes in the neck where there's involvement, and also extended down to the clavicle here to encompass possible microscopic disease in the lower neck as well. So this is, and it may vary, it is a clinical evaluation that you need to do to decide which lymph nodes. But this is an example just to show you that for patients who are not having chemotherapy, and therefore we need to include microscopic disease, this is the sort of volume that you would expect to include.
Thank you. Another question from the audience. Dr. Bhausahib wants to know preferred timing of radiotherapy in early stage NKT NHL.
Yes, that is an important question because in NKT cell lymphoma, the effect of chemotherapy is still not that certain. So we need to get radiation therapy in early. What I do is usually, if I can get away with it, and the patient tolerates SMILE treatment, we give 2 cycles of SMILE, and then we go in with the radiation therapy, which is again more extensive volumes than you would use in for instance, diffuse large B-cell lymphoma, where we have effective chemotherapy. And we have, in fact, just had accepted in the International Journal of Radiation Oncology, Biology, and Physics our ILROC guidelines on NKT cell lymphoma, where this is specified. It is important to give radiation therapy early. And in the Chinese, in China, where they have many cases of these, they diagnose them earlier than we do. I don't know what happened in India, whether you are also more aware of these patients. They're very rare in the West. And so we usually see them when they have fairly advanced disease. But if you catch them at a very early stage, you can, in fact, treat them with radiation therapy alone. I never do that because I've seen too many patients progress during radiation therapy. So I try to give them 2 cycles of SMILE, but then I get in with radiation therapy. It's important to get it in early. And if the patient responds poorly to the chemotherapy, it's even more important to get the radiation therapy in early.
Okay, Dr. Lina, you can go to your next slide.
Favorable Hodgkin lymphoma, IPAD negative. Well, it's a question of avoiding involved site radiation therapy. So who's asking the question? Would they like to elaborate?
Yeah. Hello. Yes. Hello.
Yes.
Hello.
Go ahead.
Yeah, this is my question, sir. Can radiotherapy be avoided in early stage Hodgkin lymphoma if at all the patient is complete metabolic response? And we recently had a 17-year-old boy who had a stage 2 favorable Hodgkin disease who received 2 cycles of ABVD. So after CR, our radiation oncology colleague, we referred the case to our colleague. So they omitted RT, but in 2 months in the mediastinal, he had a 2 centimeter lymph nodal recurrence. So if at all in such cases, he had only a recurrence at that point, we can give RT and observe him at that point of time.
Yeah, you're touching on a very important problem here. And as I mentioned previously, you can avoid ISRT in PET-negative patients, but you will lose some tumor control, around 8% from the trials that we have. And I don't think 8% is trivial in a disease where the recurrence rate is so low. In fact, an improvement in progression-free survival of 8%, if that were a chemotherapy regimen, you would switch to it. And many of the trials that we've done in the past, which have been practice changing, have not achieved more than an 8% improvement. So I'm actually quite wary of people just thinking 8%, that doesn't matter. I think it does. And I would not have omitted radiation therapy in this case. But You can use it in selected cases, but then you need to consult your radiation oncologist to know what risks of toxicity will you actually avoid in this particular case. Does the radiation therapy that you would give, what risks would it give? Because if the risks are trivial, then it's really pointless omitting the radiation therapy and risking recurrence. But and also you need to consider this young boy would obviously be able to tolerate relapse treatment, even if it was high-dose chemotherapy and autologous stem cell transplant. But in older patients, it's even more important not to risk recurrences because they won't tolerate the relapse treatment. But what you did there is that you had then an early relapse shortly after you finished the chemotherapy. And in my institution, it used to be simply the routine that they were taken on to high-dose chemotherapy and autologous stem cell transplant. But in the RAPID trial, the British randomized trials of omitting radiation therapy in PET-negative patients, they actually had some cases like the one you report here, where they had early after the end of chemotherapy a recurrence, and then they simply gave the patient the radiation therapy that the patient would otherwise have had initially, and no more than that. And that's what you did. And I think that is a very attractive way of dealing with it, because if the recurrence shows up a couple of months after the radiotherapy, chemotherapy, then the risk of further dissemination is probably very small. And what happened here is that it's just an indication that this patient was one of the 8% that would have benefited from having the radiation therapy up front. Then you just give it now and hope for the best. And I think that's critical. What I do think is that in this situation, I would irradiate the whole of the initially involved volume and not just the recurrence volume. Because if it recurs in one place after the chemotherapy, then I would suspect it might recur in some other place in the initially involved area after a couple of more months. So I would give the radiotherapy that the patient would have had if the radiotherapy had been given as part of the primary treatment.
Thank you. Thank you, Dr. Sterren.
Thank you. Thank you. Thank you.
I'll take a question from the audience. Dr. Lahoti wants to know that if you have an advanced stage classical Hodgkin lymphoma who has received the treatment with ABVD and the post-treatment PET scan shows Deauville score 4 at one site, but the biopsy comes negative, will you give radiation to that area?
If that area is an area that was involved initially and it has responded but not completely, I would frankly, I'm always very cautious about these biopsies. I do head and neck cancer as my other area, and we very often see this, that you do a biopsy and it's not representative. It's very difficult for the ultrasound people or the surgeons to find exactly the area that is PET positive on a scan. So I very often suspect that it may simply be that they haven't just got the right sample from the right area. So if I do think that it is likely, it seems plausible that this patient would have residual disease in this area, I would still treat it as residual disease.
Thank you. You can take your next case. Whose case is this?
Yeah, it is mine.
Yes, sir.
Go ahead. Bhavin, go ahead.
Yeah. So, madam, it was an excellent presentation. Most of the questions we have is answered by you. I want to know that many patients presented with bulky Hodgkin's disease or diffuse large B-cell lymphoma, and they have very good response to chemotherapy. After 2 cycles, they become PET negative, and even at the end of the treatment, they are PET negative. So, whether we can avoid radiotherapy in such group of patients?
Interesting question. We are sorry, I just need some water. At the moment, I have a PhD student who's analyzing relapse localizations in Hodgkin lymphoma and diffuse large B-cell lymphoma. So this is just spot on. And in Hodgkin lymphoma, it seems that there aren't that many recurrences, of course, but they do not seem to be located preferentially in initially bulky sites. We can't find any initial characteristic that will tell you where the recurrences will occur. It isn't either in a particularly FDG avid area it recurs. So I must say that if the patient achieves complete remission, complete metabolic remission, I would not irradiate an initial bulky disease. I know it is done a lot. It's actually because it seems so logical that patients with bulky disease have a higher risk of recurrence, so we irradiate the bulky disease. But the fact is that they do have a higher risk of recurrence, but it's not necessarily in the bulky disease. So you don't know what to irradiate. So if the patient has, advanced Hodgkin lymphoma and has a complete metabolic remission, I wouldn't irradiate anything. For diffuse large B-cell lymphoma, it's different. I'm not so sure. First of all, remember the Recover North and Unfolder and Optimal studies, which I'm not so sure demonstrates that you can avoid radiation therapy, even if the patient has achieved a complete remission. And in diffuse large B-cell lymphoma, the recurrences do seem to be located in initially bulky site. So I think those are, and it's pretty obvious if you think of the histopathology of these diseases, they're very different, and you can't extrapolate from one to the other. And in diffuse large B-cell lymphoma, I do think that even if you have achieved a complete remission, then I'm not sure I can avoid irradiating the bulky disease.
Thank you, ma'am. Thank you.
Thank you, Bhavin. We'll take another question from the audience. Haridas Nair wants to know, is there a role of radiotherapy in pediatric Hodgkin lymphoma?
Pediatric Hodgkin lymphoma is not my specialty. I have a PhD student who's just defended yesterday her thesis on, or the day before yesterday, and it is actually quite rare. In the pediatric protocols, the definitions are different. They actually more irradiate advanced disease rather than early disease. So I wouldn't try to have any opinion on the pediatric protocol. The European pediatric protocols are not using radiation therapy nearly as much in children as we are in adults. And for obvious reasons also. First of all, they are more often advanced disease, and secondly, the considerations of side effects are much more important here.
Okay, I agree. So we will take up another question from the audience. Dr. Umi wants to know about the role of whole brain radiotherapy for primary CNS lymphoma. And second part of the question is preferring the local confirmed field due to lessening the irradiation volume.
In the ILRO guidelines, we specified that we advise whole brain radiation therapy, and that is because the primary CNS lymphomas, as you well know, are usually widely disseminated in the brain. On the other hand, I know that other centers have been doing differently, but I know one center in California, but I haven't seen any reports on their results. But the role of radiation therapy or whole brain radiation therapy is really interesting here, because the randomized trials that they've been doing in the IELSG demonstrated to them, much to their surprise actually, that consolidation with autologous stem cell transplant or whole brain radiation therapy gave the same results. They had obviously expected that high-dose chemotherapy and autologous stem cell transplant would be much more effective, but they gave the same results. And I think another important point about whole brain radiation therapy is that the data from Memorial Sloan Kettering demonstrate that for patients who achieve a complete remission with the systemic treatment, then the consolidation treatment with whole brain radiation therapy needs only to go to 24 gray. And with 24 gray, they have much less neurotoxicity and much less cognitive decline. In fact, so little that it's really hard to find it. And I think this is a very, very interesting area. I've been doing it sometimes myself, even in patients who have not achieved a complete remission, but who were very anxious and afraid of the side effects, obviously, for obvious reasons. I've been giving just 24 gray. And some of them have been really, really living for very long and functioning very, very well. So I think this is an area we need to explore. Do we really need to go to 40 gray if there's even if there's not a complete remission, or is 24 gray a solution that would give a much better balance between long-term side effects and effect? And other point I think would be extremely interesting to explore is to do hippocampal sparing. And I'm actually thinking of setting up a protocol like that in the Nordic Lymphoma Group. So I think this is a very an area where a lot of questions are still arising, and I would like to see some results of those centers that have been doing partial brain irradiation. And I wonder, have you got any experience with that?
Dr. Siddharth, you want to add?
Yes, we do a modified kind of thing. We do low dose whole brain and then boost the gross disease to 40 gray. So that we've been doing for some time, but we've not gone away completely from whole brain.
No. Okay, it would be interesting.
We haven't done that.
You need to publish that. I'm sure you have a lot of patients. You always have.
Yeah. Yes. So we are looking at it.
Good.
Right. Dr. Lena, you can go to the next slide. This was the next slide.
I think this is the next slide.
Yes.
So this is my question.
Yes.
End of treatment, the many patients with Hodgkin's lymphoma, diffuse large B-cell lymphoma, PET positive by dual 4. Now we do the biopsy confirm that it is because of the disease. So whether the involved site RT is optimal treatment if the disease localized to one part at one site only, or whether we should consider for a salvage chemotherapy followed by autologous stem cell transplantation.
Yeah, and I think that is a very important question. And as I mentioned previously, there is experience in Hodgkin lymphoma from the RAPID trial, where if you have an early PET positivity after you've finished your systemic treatment, then they went along and just gave the radiotherapy that they would have given if they had aimed at combined modality treatment in the first place. So simply giving the radiotherapy that the patient obviously then needed. And they've had good results with that. They haven't published it yet. And it's only a few patients, of course. It's always the problem, which is a luxury problem, of course, that we have so few recurrences that we don't have large data materials. But that has been done in Hodgkin lymphoma, and I would certainly do that. If you have a lesion that is still PET positive after systemic treatment, I would irradiate it. And in many cases, avoid any further very toxic treatment. For diffuse large B-cell lymphoma, I would say it would be worth a try if it's located in exactly the initially involved volume, and there's been some but not adequate response. In that situation, we know from published data that you can achieve a complete metabolic remission in about 85% of cases by adding radiation therapy. But it's a bit more uncertain in diffuse large B-cell lymphoma, as I mentioned previously.
Thank you, ma'am.
One more question from the audience. Dr. Krishna Ratnam wants to know, localized DLBCL, 4 cycles of R-CHOP given. Now, who is the patient whom you will give radiotherapy and whom you will not? A PET is negative.
Well, the PET is negative.
Yes.
Well, frankly, I think that that depends on if it was in an area where it would be very toxic. But in most cases, I would advise to have the radiation therapy. Our standard treatment is actually 3 cycles of R-CHOP and then in multi-site radiation therapy. And in that situation, I think you achieve the highest chance of permanent cure in these patients. And they very often have fairly limited disease and rarely in the mediastinum. So it's very, the side effects that you are should be considering are fairly minimal in most cases.
Thank you. You can go to your next slide. This is the one.
Yeah. Yes, whose case is that? or if nobody has a case, then it's a question of the recommendations for follow-up in a young patient who's had mediastinal radiation therapy. And patients who've had mediastinal or are going to have mediastinal radiation therapy, I always give a very serious talk on smoking, because we know that the secondary lung cancers, they practically, you only see them in smokers. So these patients need to stop smoking permanently. And otherwise, for the follow-up, there isn't really any very good evidence. But, and it depends on which organs were irradiated and to what doses. So with modern radiation therapy, it's completely individualized, and the patient should have this consultation with the radiation oncologist after the treatment plan has been devised, so that you can see what doses you're actually giving to any organs. For breasts in young women, and really that is under the age of 30, I advise this clinical mammography screening 10 years after the end of treatment, with whatever is the advised methods of screening at that point in time. If the heart gets any dose, then I would advise them to keep all other risk factors for heart disease as low as possible, meaning that they should stop smoking, they should keep fit, and avoid becoming overweight. And then a yearly blood pressure, blood glucose, and blood lipids, because if they get, for instance, diabetes 2, then it would be even more important to have it treated, because there's another risk factor for heart disease. But it is not in any way evidence-based. You don't have large data materials that can demonstrate for you. And I haven't seen any tests that would really change the outcome for patients. So, I mean, echoes or whatever, I haven't seen any indication that in asymptomatic patients that this is going to make any difference for their outcome. I don't know if any of you have any experience with that.
Not really.
No. I think that there isn't any evidence, and I think it's also important in these patients not to make them feel sick for the rest of their lives. And then if the thyroid has had a dose, I would advise them to have a yearly TSH.
Right. One last question from the audience. Dr. Kareem, DLBCL with intestinal involvement, 6 cycles of R-CHOP, complete remission, relapsed after 1.5 years, stage 3B, received salvage chemotherapy followed by autologous transplant, again in complete remission. Should he give radiotherapy to prevent the relapse, especially as the gut was involved?
So the question is, what part of the gut was involved? Was it the intestines, or what is the colon, or was it localized, or was it in? Because if it's in the intestines and it's sort of widely disseminated and the intestines move and so on, it is very hard to make a sensible radiation volume out of it. Because you need to go to a fairly significant dose here. And so you can't just give the whole abdomen. If you had a localized recurrence, for instance, in the one part of the colon, and in a fairly fixed part of the colon, you could certainly irradiate that volume. And I would do it because for this patient, it is important to achieve permanent control, and the patient doesn't have that, really have a good chance if it recurs again. But if it's disseminated in the intestines, I don't have a good technique of doing this. I don't know about you, Siddhartha, if you have any advice on this.
Okay.
Not really. We, in patients with disseminated disease in the abdomen, we would probably try to see what is the site of disease which would deserve radiotherapy maximum. Maybe going down to the site which had big disease, or we have suspicious residual. But otherwise, except for palliating with radiation, I don't think there's an option with radiation.
Agree.
Right. Sachin, you are here. You put a question in the chat box. You want to ask? Sachin, are you still there?
No, sir. Dr. Sachin has logged out.
Okay. He has put a question that if after chemotherapy there is a persistent disease in the inguinal lymph node, DLBCL, will you give radiotherapy there? And what will be the long-term adverse effects of giving radiation to that area?
In the inguinal area?
Inguinal, yeah.
Yeah. Well, I certainly would give radiation therapy there. And if it was a residual disease, it's an active disease after chemotherapy, I'd go to 40 gray. There is a risk of some edema of the lower extremity because obviously, well, very often that will have been operated as well in that area. And then if you irradiate, you will certainly get, you will in many cases get some problem with the lymphatic drainage. But I usually, and in this case, that may not even have been operated there. Usually, it's not very serious. The patient may need to put his foot up whenever he sits down or something like that. But that is really the only long-term side effect of radiation therapy in that area.
Thank you, Dr. Karun. You want to ask a question?
Yeah, ma'am. Thanks for the wonderful presentation, ma'am. I have a query. I have a patient, 30-year-old software engineer, Hodgkin's stage 4 with some mediastinal disease also. He received 2 cycles of ABBD, which was we had partial response. Then he received 4 cycles of BACOP. He went into almost complete remission, except a mediastinal node, which is of Duvalli score 3. This node was 1.2 centimeter. So how would you follow up this patient with a score of 3 post 4 cycles of BACOP?
Well, a score of 3, we'd actually regard that as complete remission and would consider the patient being in complete remission. If we weren't a little bit in doubt, I mean, this patient has responded. You are not just completely satisfied with the end result. And then we would do a new PET scan 2 or 3 months afterwards.
Okay.
Follow it, but not go to any treatment until we were sure that there was really active disease there. And you do quite often see that there may be some residual abnormality in a place where you had a large and very significant abnormality in the beginning, and that it simply goes away if you wait long enough.
Any role of biopsy here at this level, ma'am?
Any role of what, sorry?
Biopsy at this level.
Yes, well, it would always be nice to have a biopsy, but in the mediastinum, it's really a major thing to get a biopsy. And our surgeons are not too happy with doing that. So in that situation, I wouldn't be too happy either, because it is usually quite difficult to get a biopsy there. And if I think that this node has responded quite well, but not just quite incomplete. I actually, as I said, Deauville 3, I would regard as complete remission. But if that is the case, I would rather wait and see 2 months later a new PET scan and see whether it has, it usually goes away.
Yeah, this patient I waited for 3 months, and the repeat PET CT was a score of 2, ma'am. It's a complete remission.
Score of 2, so it was complete. Oh, that's good.
And ma'am, one more thing, just out of curiosity. So 30-year-old male with a mediastinal mass, is there a way to, can we just grade the toxicity of radiotherapy versus chemotherapy? Say 30 gray radiotherapy versus 2 cycles of BACOP, or 20 gray RT versus 2 cycles of ABVD. I know scientifically we can't compare different modalities, but just get an idea how toxic it is.
For the heart, as you saw in the curves I demonstrated from our analysis of the randomized trials from the EOTC, we could actually deduce that 1 cycle of or 50 milligrams per meter square of anthracycline gives the same risk of cardiac event as 5 gray mean dose to the heart. So you can titrate these two and see what is actually giving you the most. But then you need to do a dose plan to see how much dose the heart actually gets. And we are using routinely, and we are advised that in the ILMOG guidelines as well, to do deep inspiration breath hold, because if you do that, you will in many cases remove the heart posteriorly and inferiorly, so that it is taken almost completely out of the irradiated field. That's why we can keep the dose, even for patients with mediastinal Hodgkin lymphoma, on average below 5 gray, below 4 gray actually. So that is a very small dose. So if you are giving extra chemotherapy and just one cycle, that will actually give you as much toxicity as the irradiation in many cases. But it needs to be evaluated in each individual case. And then it depends on the distribution of the disease.
Yeah. Thanks, Dr. Karun. Ma'am, you can go through your remaining slides.
This was the primary CNS factors predictive of radiation therapy toxicity. I believe that was, yes, that was question 14.
Yeah, madam, I have this question. So in primary CNS lymphoma, the patients who had responded very well to high-dose methotrexate and who achieved complete metabolic response, we tried to avoid radiation considering the radiation toxicities. But many patients who achieved partial response, and we have to add the radiation to achieve a better tumor control. So which are the predictive factors to consider that this patient has high risk for radiation toxicity?
Well, age, of course, and older patients really are affected the most, and previous methotrexate treatment, as you mentioned. And then, of course, the radiation dose. And as I mentioned previously, we used to go to 40 gray for active disease, but there are promising results with just 24 gray in patients with well, this was supposed to be CMI. That was late last night. I did this, but even in patients who have not achieved a complete metabolic remission, I have had really surprisingly good results with 24 gray, and that gives much less risk of cognitive defects later on. And then I would consider, and we'll do that as a trial, to do hippocampus sparing radiation therapy in this situation. But I mean, in many situations, you don't have a choice, do you? Yeah. We try to avoid radiation therapy, and we don't use it as a plan for our initial treatment of primary CNS lymphomas, only for recurrences.
Sure. Okay. Thank you, madam.
Dr. Lena, you can go through your remaining slides.
Omission of radiation therapy, I think we have discussed that quite a lot in early stage Hodgkin lymphoma. So there are responses to that. And the current role of radiation therapy to bulky decides in diffuse large B-cell lymphoma in patients in complete remission. We also have discussed that quite extensively. Can radiation therapy be omitted in advanced Hodgkin lymphoma if the patient is in complete remission after 6 cycles of APD? A big yes. I wouldn't use radiation therapy in that situation. The current role of radioimmunotherapy for recurrent follicular lymphoma after curative radiation therapy. Well, it's a sad story because it's a very effective treatment, but it has not gained popularity. It's simply gone out of fashion. And I guess it's partly because of poor marketing in a way, because it is a very effective treatment, but we're not using it. And I don't know, are you using it anywhere in India?
No.
No.
Not at all.
No. So I think that was my last question, really. Yes.
If there is anybody over here who wants to ask any question, appears that everybody has got everything that they wanted to know. So, Dr. Lena, what should I say? It was wonderful. Almost 2.5, 3 hours. You answered every question, however silly it was, very patiently. And your talk, of course, was out of this world. I'm grateful to everybody over here, including our chief guest, Dr. Siddharth Laskar, our faculty from India, from all corners of India. They put up all these questions to you in advance, and you had an opportunity to prepare slide. The hard work done by you could be seen. And of course, your talk, what should I say? Thank you so much.
Thank you so much. It's been a pleasure. And I think it's so interesting because we get this discussion. And so I think that's wonderful. Thank you very much.
Thank you and have a wonderful day. And thanks to everybody over here.
Thank you.
Thanks to Dr. Reddy's.
Thank you.
Thank you, everyone.
Thanks to Mice Ideas for managing.
Thank you very much. Hope to see you all soon.
Bye-bye. Have a nice day.
Bye-bye.